So, um, imagine for a second that you're sitting in a doctor's office.
Oh, yeah. On that crinkly paper gown.
Right, exactly. The fluorescent lights are humming, you're shifting around trying to get comfortable, and the clinician looks up and asks that classic question, you know, can you rate your pain on a scale of 1 to 10?
It's like the universal medical greeting at this point.
It really is. And usually you have a solid reference point, right? Like a sprained ankle or a bad burn, maybe a surgery you're recovering from.
Something tangible.
Yeah, but consider what happens when the pain you are trying to describe is located in a highly intimate area, and it's completely invisible to the naked eye.
Right, there's no swelling, no obvious inflammation.
Nothing. But it still entirely dictates your quality of life, It affects your relationships, your whole sense of self. How does a doctor actually measure, let alone treat something they can't see on an X-ray?
That gap right there, that gap between what you're feeling and what the doctor can actually see is, it's one of the most frustrating dilemmas in medicine.
I can imagine.
Because historically, when doctors can't visually confirm a problem, they've really struggled to validate the patient's experience, which, is terrible for the patient's long-term care.
Which perfectly sets the stage for our deep dive today. We're getting into the source material on dyspareunia, specifically provoked vestibulodynia, or PVD.
Yeah, the data on this is actually pretty staggering.
It really is. We're talking about a condition that affects roughly 10 to 20% of women in their lifetime. But our mission today isn't just to talk about how common it is.
Right.
We want to look at the exact clinical significance of moving away from just guessing at pain levels and instead using this specific tool, the Vulval Algometer.
Which is such a massive leap forward.
It is. We need to break down how applying exact mathematical pressure completely changes how this condition is tracked and treated over time.
Well, to really get why the algometer is such a big deal, we have to talk about what it's replacing. Because for decades, patients with PVD were mostly evaluated through this psychosexual lens.
Like it was all in their heads.
Basically, yeah. If a doctor looked at the tissue and didn't see an active infection or a visible skin issue, the default was often just to assume it was, somaticized anxiety.
Wow.
Or a psychological aversion to intimacy. The actual biology of the pain was just minimized because, frankly, they didn't have the tools to measure it.
So even when they tried to measure it physically, the sources say the gold standard was, and this is wild to me, the cotton swab test.
Oh, the Q-tip test, yeah.
Right. So a clinician literally takes a standard Q-tip and touches specific spots on the vulvar vestibule, like the 4 and 8 o'clock positions near the Bartholin glands. And then they just ask the patient to rate the pain.
I mean, the intent was good. They wanted to map out the allodynia, which is pain caused by something that shouldn't normally cause pain.
Sure, but let me unpack this, because using a Q-tip to measure pain seems like trying to measure the temperature of a bath using different people's elbows.
That's a perfect analogy.
Like, how hard is the clinician pressing? Is the swab wet? Is it dry? If it's a doctor at 8 a.m., maybe they use a light touch.
Yeah, and by 4 p.m., they're tired, their hand is fatigued, and they're pressing way harder.
Exactly. So how on earth do you rely on that for actual science?
You really can't. The scientific literature calls this a lack of inter-rater reliability. If you can't standardize the mechanical force you're applying, you just can't trust the pain response you're recording.
Because the inputs are all over the place.
Right, but there's another massive flaw with the Q-tip test, which is the floor effect.
Oh, right, the control group issue.
Yeah, if you take healthy women without PVD and you do the Q-tip test on them, they feel absolutely zero pain.
Which sounds like a good thing, normally.
Well, sure, for them. But mathematically, if your control group is locked at 0, you can't build a true sensory spectrum.
Ah, I see.
If your tool can't capture any baseline sensory data in healthy people because it can't add incremental pressure, you're essentially operating in the dark.
So the Q-tip just asks, does this hurt? And we needed something way more precise. Which brings us to the Vulval Algometer.
Yes. Devices like the VQuest or those traditional 5 to 7 piece sets, they are brilliant pieces of engineering.
Because they actually quantify the pressure.
Exactly. They're handheld, highly calibrated instruments. They apply perfectly controlled, exact mechanical force to the tissue. So the whole guessing game of how hard am I pressing is gone.
And the sources get super specific here. Clinicians are using instruments that measure from like 3 all the way up to 950 grams of force, or up to 8 millinewtons.
Yeah, the precision is incredible. And they apply it totally perpendicular to the surface.
So they're not accidentally poking a muscle underneath.
Right, that isolation is key. You target just a few square millimeters of the mucosa without hitting the pelvic floor muscles.
So the goal is to find the exact PCT, the pressure pain threshold. Basically, the exact gram of force where touch crosses the border into pain.
Yes, the PPT and also the PP-toll, which is the tolerance, the maximum they can handle. And finding that PPT boundary yielded one of the most staggering findings in all the literature we reviewed.
The comparison to healthy controls, right?
Yeah. When they used the Algometer, they found that a PVD patient's threshold for pain is essentially identical to a healthy woman's threshold for mere touch.
Wait, so the amount of pressure it takes for me to just feel that a device is touching me
Is the exact same amount of pressure that triggers active, intense pain for a PVD patient.
that is wild. The body's alarm system is just completely miscalibrated.
It's like registering a light breeze as a hurricane. And that mathematical proof, that changes everything. It completely destroys the old idea that this is just anxiety.
Because you have hard numbers proving the tissue is hyperreactive.
Exactly. It makes the pain a measurable biological reality.
But having that number in a grams doesn't just look nice on a chart, right? It actually changes how you diagnose it. Because dyspareunia isn't just one single thing.
Far from it. It's a total umbrella term. And using the Algometer lets clinicians phenotype the exact type of pain a patient is having.
Like figuring out if it's just the localized skin, the mucosa.
Right, you could have localized hypersensitivity in the posterior vestibule, for instance, or the Algometer might help reveal it's actually a constricting hymenial ring.
And then there's the muscle component, too. The sources talked heavily about pelvic floor muscle hypertonicity.
Oh, huge factor. When the pelvic muscles are locked in chronic tension, that massively exacerbates the pain. And you treat a muscle problem very differently than a primary mucosal problem.
But here's where it gets really interesting for you listening. They didn't just test the pelvic area with these devices.
No, they did quantitative sensory testing all over the body.
Right. They tested the deltoid on the arm, the forearm, the shin.
Hmm.
And women with PVD often had dramatically lower pain thresholds in those completely non-genital areas.
Which is a massive paradigm shift, because if your shin is hyperreactive to pressure, we're not just looking at a localized genital issue anymore.
We're looking at a system-wide alarm.
Exactly. It's what we call central sensitization.
Okay, but let me push back for a second, just playing devil's advocate. If someone with severe pelvic pain is in a clinical setting, knowing they're about to be examined, they're going to be incredibly anxious.
Oh, absolutely.
So how do we know their arm is actually more sensitive on a neural level? And it's not just like situational adrenaline making them jumpy.
That is a great question, and it's exactly why the exact math of the Algometer is required. Because acute anxiety can definitely lower your pain tolerance, the maximum you can handle.
Right.
But central sensitization changes the minimum threshold. It alters how the spinal cord and brain process basic sensory input from the ground up.
So the hardware itself has changed, like a home security system where the sensors are degrading. So instead of alarming when a window breaks, it goes off because a leaf blew past.
Yes.
Huh.
The Algometer proves the sensor is misfiring regardless of how anxious the patient is in that moment. The central nervous system is just stuck in this dysregulated feedback loop.
So it's amplifying everything.
Exactly. It treats non-painful stimuli as painful, which means PVD for many patients is actually a complex, centrally mediated chronic pain disorder.
Like fibromyalgia.
Very much like fibromyalgia. It just happens to interfere with sexual function because that involves dynamic pressure on very sensitive tissue.
And the fMRI studies in sources back this up perfectly, right? They literally put patients in an MRI and applied pressure to the vestibule using special algometers.
Yep, MRI-safe ones. And the scans showed that the insular and frontal cortical regions of the brain just lit up way more than in healthy controls feeling the exact same pressure.
And the insular cortex is the part of the brain that handles like the emotional reality of pain, right?
It processes the subjective unpleasantness of it, yeah.
Yeah.
So the brain is interpreting a safe light touch as a high-priority severe threat.
Wow. But, okay, knowing all this, knowing a patient's pain triggers at exactly 15 grams, and their brain is lighting up, that's just the starting line.
Right, the diagnosis.
Yeah. The real value is tracking that 15 grams over time, which brings us to longitudinal tracking, right?
Definitely. Because treating this takes a multidisciplinary approach. There's no magic pill.
The sources mentioned multimodal physiotherapy, cognitive behavioral therapy, topical lidocaine.
Biofeedback, yeah. It takes months of intense intervention, and to know if any of that is working, you need a flawless way to measure progress.
And apparently, we used to use something called the tampon test.
Ugh, yes. Patients would insert and remove a dry tampon over weeks of treatment and rate their pain.
Which sounds awful, first of all. But also, scientifically, it's just bad data, right?
It's terrible data. A dry tampon creates generalized frictional drag across the whole vaginal canal. It doesn't mimic the dynamic, highly localized pressure of sexual intercourse at all.
So you wouldn't know what tissue was actually hurting.
Yeah, exactly. Too
No.
many variables. But with an algometer, you get a pure numerical baseline. So week 1, pain hits at 10 grams. Week 12, after lots of therapy, pain hits at 60 grams.
Which brings up a really crucial point for anyone going through this. If you're going to physical therapy and CBT for months, you need to know, is the tissue actually healing, or am I just getting mentally tougher?
Yes. And the algometer isolates those two things completely. It separates physiological progress from cognitive progress.
Because CBT, as great as it is, doesn't physically change the nerve density in your mucosa.
Right. CBT targets pain catastrophization. It helps you decouple the intense fear of pain from the physical stimulus itself.
So you can feel the pressure and tell your brain, this is uncomfortable, but I am safe. This isn't tissue damage.
Exactly, which massively reduces the distress. But clinically, we have to know, did the therapy reduce the physical sensitivity, the hyperalgesia, or did it just improve the patient's coping mechanism?
Both are great outcomes.
Of course, both vastly improve quality of life. But they're distinct biological mechanisms. So if a patient does 12 weeks of CBT and feels way better, but the algometer shows their pain threshold is still exactly 10 grams.
Then you know the physical nerves are still sensitized, but the brain is handling it better.
Exactly. But if they do pelvic floor physio and their threshold jumps from 10 grams to 60 grams, you have hard proof that the physical tissue itself was rehabilitated.
That is so empowering. The hard math required to prove a treatment actually works on a biomechanical level.
And that's what moves these treatments from being experimental into standard-funded medical protocols. It ensures a patient with central sensitization isn't given unnecessary local surgery and vice versa.
It just fully pulls PVD out of that dismissive, unexplained pain category. It forces the medical world to respect it as a measurable neurological and physical reality.
It really is a shift in how modern medicine respects the human sensory experience.
And as we wrap up our deep dive on these sources, the expert analysis here really leaves you with a profound question about the future of this technology.
It does, because if we have instruments like the algometer that can mathematically map the exact border where touch becomes pain,
Yeah.
could we use the same logic for the opposite spectrum?
Wait, you mean mapping pleasure?
Yeah. Imagine using quantitative sensory tools to establish a biomechanical baseline for human pleasure. We could treat conditions like anorgasmia with the exact same precision.
That is fascinating. Like finding the absolute threshold of pleasant stimuli to rehabilitate positive sensations.
Exactly, yeah.
Applying exact engineering to joy instead of just pain. That completely changes how we might view our neural wiring in the future. So the next time you think about how medicine measures our physical limits, remember that those same tools might one day map our capacity for pleasure.
It's a pretty incredible thought.
It really is. Thank you for joining us on this deep dive.